Jim. John, very interesting. Um, I think the first question, leading on from one of the slides that John showed us, which was a very stark picture of what we're facing over the next 10 years in terms of the country aging. And as John put it very well, we're aging on speed, I think is how he phrased it. And it's going to happen very, very fast. What are and it's going to happen to your membership very, very fast too. What are your plans for the next few years to deal with an aging membership? And maybe there's two parts to this question. You see a role for the insurers getting involved in treating chronic illnesses and perhaps doing so in a way to save you some costs?
Well, I think, sorry, James, I think I think the key point here is that as the population, but in particular the health insurance population, ages, okay, we are going to be faced with many challenges, in particular chronic disease management. And I think many people have alluded to different ways. We're just going to have to think of different models in managing chronic disease. And I think that may require some integrated care models that a combination between primary care, maybe subacute, acute. And I just think there's different ways that we're going to have to manage this, because the problem is that if we continue doing some of the things that we're currently doing, we're going to put health insurance premiums, and clearly that's my or Jim's agenda, out of our customers' reach. So we just need to manage. I think we're very open, and I think we've both said it. We're very open to look at ways and methods and ideas where we can work together to make sure that we get. The twin approach is that we keep healthcare affordable and we deliver better healthcare solutions for our customers or your patients.
Thank you, John. Jim, sure. More for less, is it?
Yeah. It's an interesting one. I think it goes back to the point earlier. We have a community-rated system. And a critical part of a community-rated system is we have a critical mass of a younger, healthier population that can subsidise the costs for the older population. And that goes back to the point about ageing, that if we don't continue to find opportunities to attract corporate clients in who are typically healthier, younger people into the market, well then the cost of premiums for everybody will be something that causes a tipping point in our system. But when we talk about chronic disease management, there's another consideration here which I think is about the state of our community-rated system. It was designed decades ago, and I believe it needs to be adapted. And Jim Breslin earlier on this morning was talking about the key risk factors in relation to chronic disease, and this was about exercise, about alcohol, about smoking, about diet, and so on. They're all behavioural issues that we can address and we can influence. So I would suggest we need to be looking at our health insurance regulation and looking at an environment where we can create multi-year contracts, where we can work with clients and we can have meaningful relationships, where we can put in place care programs and customers can participate in those care programs. And if they do, well then they have an opportunity to have a lower cost for the health insurance than if they don't. So somehow or other we have to create an environment where we can start encouraging people to make steps to intervene in the quality of their own health, because it just won't be sustainable. I think the number we saw earlier on was 4 to 5% increase in chronic disease cases on an annual basis. That will absorb a huge proportion of our health budget in the years ahead. So we have to find new ways of intervening to reduce it.
Thank you, Jim. There's been a lot of debate this morning about the various proposals coming out of the Oireachtas Committee on the Future of Healthcare. And the one that seems to be grabbing most attention is the idea that you can disentangle the private element of what's going on in public hospitals. And the idea behind it is that it will create extra capacity in the public system to reduce waiting lists. You've heard a view expressed here earlier that in fact that's not going to happen, that the vast majority of people, I think 70% of the people who end up in public hospitals are emergency cases, so they're not going to go anywhere else. Do you agree that it's not going to create the capacity that they hope it will create. Jim?
I suppose an observation on the Oireachtas report, it's one that everybody welcomes. Nobody can argue with the ambition and the aspiration that's in it. But as was said earlier on, I think by Leo, that it's not a plan. The plan needs to be developed. And there will need to be serious thinking in terms of what sort of system will we need. And I think there will be opportunities there for private health providers to step in. So for example, let's take maternity care, let's take paediatric care. How is the overall model going to work? Who will need to provide certain services that, to make them available both to public and to private patients? And I think the key challenge that we have here is that we need a real collaborative approach to designing what the implementation plan for the committee's output will look like. So I don't think it's going to be so simple that we'll just be able to pull the shutters down and that there will be no more treatment of private patients in public hospitals. It's just not going to work. It's not that easy. But there will be a need for huge detail to be ironed out and for us to actually step back and try and architect a system that really makes sense and is going to work. And my own view is that that needs to be a strong collaboration between private and public stakeholders. And that's something that we haven't done before. So it's going to take a real mindset change to try and paint a picture of what a new system could look like.
I think I agree. The Oireachtas report has to be welcomed. However, I think the point you're talking about, the disentanglement, I think I can understand why somebody puts that forward. I understand all the arguments. However, lots of people have come up with strategies in all sorts of businesses. The implementation of it is another challenge, and I believe that the implementation, and when we get down into the detail, we've heard some of it this morning, will be a huge, huge challenge. There is, and I think it will take a lot more time and a lot more planning before this can be implemented. I mean, some of the history of this, we did not have a perfect solution prior to this, but we had a much better solution. And what we had was in the vast majority of cases, there was 20% of beds were allocated. They were in a smaller rooms, or sometimes what we call semi-private or private rooms, and there was a clear difference in the service proposition that people that were willing to pay that extra got, which we ensured. Now, you know, Jim, myself, and our other colleagues in this argued vehemently with the powers that be at the time that do not change the system, add more services to it if you wish. That what we're now seeing happening, we predicted would happen, and we predicted the amount of money, the exact amount of money that this would. So this is no great surprise. This actually got debated in a Dáil health committee, and some of the numbers were even put down there, but we actually said it very clearly at those meetings. I think Jim will remember one of those meetings ran on till midnight. We argued, but I think I think that system, while lots of flaws in it, is far, far better, and I think it struck the right balance between it giving a difference in service, different access, but also we recognised that the public system needed money. This was one way that they got money, but it was from a health insurance customer's perspective, they got a different service. Today, that's very limited, the difference in service, and I think this is a real challenge for us all, and solutions and investigations will have to take place, will have to be found. But I do believe the implementation of what's at this point in the Oireachtas Committee will be very, very challenging and very, very difficult.
Thank you, John. Moving away from the Oireachtas Committee on the Future of Healthcare and dealing with healthcare today, one of the big issues faced by your members and the private hospitals are the vast number of plans that we have in the market. I've lost track. I think it's somewhere in the region of 400 or 500. I'm not sure at this stage. Is there any plans for the health insurers to deal with that? Because I'm sure it's not easy for you guys as well. And also, John, you alluded to it earlier on. It's the downgrading that's going on. So you have, whilst competition is good, it's also decreasing, the average premium that you guys can earn, which you're going to need to increase if you're going to be able to afford to pay the claims in future. So that's a two-parter.
Well, I think there's no simple answer to it, but can I tell? Let's say for Australia, there is thousands of products. Okay, you might alluded to a few hundred products in our market, but also I think there's a couple of things. One is that corporate customers are very demanding of tailored solutions, so they have a particular requirement for a design in a product. That product is available to every customer, but all of us will tailor our products to that particular corporate customer, and then we'll put it up. It's available for anybody to purchase, okay? So that is just meeting a customer need. But also, I think, we have in VHI, we've taken out 35 plans over the last couple of years. We have just over 70 products ourselves, by far the lowest in the market. But I also think it's fair to say that, sometimes the number of products is often, I'll give you one example. So we can have a product with 4 different excesses. That's 4 products. So if I have a product X here and I have an excess of €300, 250, 200 or 150, that's classed as 4 products. So in many people's heads here, that's one product with 4 excesses. But when I count the 70 odd products we have, that in that example there, that's classed as 4 products. So while it is complicated, and I think it's something we're all trying to manage and tackle, I think there's an excellent website by the Health Insurance Authority that makes it really clear for people what their options and choices are.
I think from a health insurer perspective or a medical provider perspective, we can talk about the number of plans in the market. But if we put a lens on where we're looking at this from a customer perspective, it's about us being able to provide customers with benefits that make sense for them. And that often requires us to develop new propositions that will work for them, whether it's corporate clients or whether it's individual clients. So we need to make sure it's no longer one size fits all. There are many, many, many different needs out there, and then you overlay that with price positions that different customer groups have. And we need to be able to provide solutions that work for everybody. And when we talk about the down trading challenge, and down trading is where people are stepping down maybe the level of benefits that they have in their plan, but maintaining a particular premium level, that is driven by one particular issue, which is the affordability challenge that people are facing. And that is something that has developed over the last number of years. So people have a level of discretionary income that they can afford to pay for private healthcare cover. But as the costs keep going up, they have to step down the level of plan they have to be able to handle that within their budget. And that's a big issue for us, and that's why we need to focus so much on the affordability challenge that's sitting out there. And if we look over the last number of years, co-pays, excesses, shortfalls, they've become more of a norm than they had been in the past. And it's not a direction anybody really wants to travel. But what's the alternative? The alternative is to keep premiums up at a level that people can't afford to be in the market. So there is a real challenge for us here, and I would suggest most of it goes back to the point about we have to find ways to make sure that the cost of health insurance and access in private care is sustainable. And if we don't do that, we will see further developments in relation to shortfalls or excesses or very, very restricted levels of cover on plans. Because customers cannot afford to buy the highest level plans in the market. And look at the example we had earlier on. In 2003, when I was talking about the amount of claims that were paid in the market, average health insurance premium was €500. Average health insurance premium now for an adult today is €1,200. And disposable income has not increased to any significant extent. So that's what's driving all of this. So that's why I say across all the stakeholder groups, we have to find opportunities to take cost out of the system so we can maintain a high level of benefits for customers and try put a break on that downgrading.
Thank you, Jim. I'll hand over to the floor. Everybody wants to ask questions in the 5 minutes and 41 seconds we have left, according to this clock here in front of me. Eamon Fitzgerald, the Hermitage.
Thanks very much. In relation to private hospitals having contracts with underwriters, there's a requirement, and rightly so, for the hospitals to be accredited by an internationally credentialed accreditation organisation such as Paula's Joint Commission International. However, that's not the case for your customers in public hospitals. And I'm just interested to know what the rationale for it not being the case in public hospitals. I can completely understand the rationale, which I fully agree with, it for being in private hospitals as a marker of quality and safety and a commitment to it. So I'd be interested in both your views on that. Thank you.
I think it's a really good question, Eamon, and a real challenge for the overall system. The way the public system works at the moment is prices and costs are unilaterally set by the Minister. We have no ability to negotiate in relation to those costs. So we're a price taker, and we know where the price has gone over recent years. That's an issue. In terms of accreditation and standards, that's also an issue. I believe going forward we have to change that, and we should have private and public hospitals competing against one another, and that we have an ability to direct our customers to wherever the best setting is and wherever they're going to get best value for the health insurance spend. It doesn't operate that way today, but it has to change. And the other issue we have, and a problem with the public system, is the reimbursement model is completely flawed. It's a reimbursement model we pay for every night that somebody happens to stay in a hospital. So it's in the hospital manager's interest that they don't mind if somebody's in there for 10 nights as opposed to 5 nights. Whereas in the private system, we pay for a procedure-based price. So somebody is incentivized to make sure they're providing the right level of treatment and they're efficient in terms of servicing the customer and then letting them move on. So the whole model in terms of reimbursement and in terms of standards, in terms of being able to negotiate, has to change. It isn't sustainable going forward. We have a restriction in terms of legislation around minimum benefits, that we have to provide certain services and benefits in public hospitals. That's a bit of a break in terms of our ability to really innovate and challenge that system. But we have to find ways to adapt it, because it just isn't sustainable going forward. And I would like to have an opportunity on behalf of 2 million health insurance customers to be able to decide that we will and will not cover certain facilities, whether it's private or public, if they are not operating to the standards that we talked about earlier on, because people shouldn't be accessing facilities that are substandard.
Any other questions? Now's your opportunity. No? Just a couple of minutes left. I might just ask one more question of the panel. We've talked a lot about the inevitable demand for healthcare over the next 10 years, and in particular from people over the age of 65, and it actually is even higher when you get over the age of 80. How is it going to be delivered? There are no new hospitals being planned. Doctors, the nurses, the allied healthcare professionals. Jim?
It's like a $64 million question there. I don't know. It's the easy answer to that. I think that is, the real challenge that has come out of the All-Party Oireachtas report. How are we going to build a system that can cater for the needs of the population? And they're coming at us in a big way. And I think it was earlier on, Francis talked about different stakeholders, and that the health sector is not the only stakeholder. If you have a look at all the other departments, they're there. So paint a picture in relation to pensions. So at the moment, we have 5 people working for every 1 person retired, and they're funding the pension bill on an annual basis through their taxes. And we know in a couple of decades that's going to move to 2 people working for every 1 person retired. And we know from research that half the people in private employment aren't contributing to a pension scheme, and that is their biggest financial worry about retirement. Their biggest worry about retirement is how are they going to be able to fund the standard of living. So we have a crisis coming at us outside of health, where the state won't be able to fund a pension bill, and people won't be able to use their own monies to fund the standard of life that they need. So will they be able to still afford healthcare? Probably not. Will the state be able to afford the same bill from a healthcare perspective? Probably not. But yet our population is aging at a rate of knots. So if ever there was an opportunity or an opportune time for a real wake-up call that we need to find solutions that work, it is now. And I hope we will build on the Oireachtas report and actually get into meaningful conversations very, very quickly about how we can turn that into an effective solution.
I think, where we and the Oireachtas Health Committee report has many fantastic things that needs to be done. When I think about the debate about universal health insurance, everybody thought it was fantastic, but the real honest discussions about the cost were not held early enough. And I know I think there's somebody going to talk to us later on this afternoon from Consumer Powerhouse, and to my best of my knowledge, the Dutch system is the number one on the on that particular survey, and they took 20 odd years to make whatever changes they needed to implement for universal health insurance, and the costs are significant. But they took time to implement it, and it was an honest discussion. I think here, I don't have all the answers, that's for sure, but I think here we have successes in Ireland where we've had focused on a couple of key issues. And I know that whether it was the cancer centres of excellence, I think was a great example where we did something really well. I think, where I hear Oliver O'Connor talked about the Treatment Purchase Fund earlier, and he was one of the key architects of it. And I think many people gave out about it. It was a focused, clear strategy to clear waiting list in partnership with private hospitals. And it worked. Like, waiting lists went from 5 years to 4 or 5 months. Okay, lots of people can have ideology about it, but if you're a customer, a patient on that list, or one of those lists, you were thrilled with that. So there is examples. And I think any business, and I recognize there is politics and in all of this, but any business can't do everything. So if we develop a strategy for VHI or Irish Life or any company, the Blackrock Clinic, I'm sure you focus on 2 or 3 things, and you try and deliver the 2 or 3 things that make it significant. When you have that done, you've built momentum, you take the next 2 or 3. And I think sometimes we try and hit everything. And I think I would have liked to have seen that we've, while a strategy is undoubtedly very good, but then was it tell me the 2 things we're going to do over the next, and just focus on those 2. Sure, there's politics at play here, maybe that wouldn't have worked, but that's what we would do in a business situation.
Great, thank you very much, John. We're over time, so I'd like to thank John and Jim for coming along today.